AIDS, the disease that attacks the immune system. You know all about it, but do you?
In 1981, doctors in Los Angeles reported a cluster of rare infections among young gay men. They had contracted illnesses that usually only appeared in people with severely weakened immune systems. It was the first official recognition of what would come to be known as AIDS. By the 1990s, HIV/AIDS had devastated communities across the United States, and New York and California were the epicenters of this epidemic. Tens of thousands of people were dying each year from AIDS. The government's response was unprecedented both in scale, as the largest disease-specific public health program in US history, and in design, channeling billions through programs like the Ryan White Care Act. But did all of this spending actually make a difference? Did the benefits of this intervention outweigh the costs? In the rest of this video, we'll give some background context on the AIDS crisis and the Ryan White Care Act, before we look at how effective this program was at saving lives. Then, we'll dig into the methods researchers used to identify these effects, including how a simple policy cutoff created a natural experiment. After that, we'll go on a short tangent to talk about how economists do and do not put a value on a human life. And finally, we'll ask whether all of this spending was actually worth it. Welcome to Econ Unpacked. The epidemic. Within just a few years of the first cases, AIDS had spread across the country. By 1985, more than 15,000 Americans had died, and new infections were being reported in every state. By 1990, the annual death toll had risen to around 40,000. For Americans aged 25 to 44, AIDS had become the leading cause of death. HIV, the virus that causes AIDS, attacks the body's immune system by destroying white blood cells known as CD4 cells. As the immune system weakens, patients become vulnerable to infections and cancers that a healthy body would normally fight off. These so-called opportunistic infections, such as pneumonias, tuberculosis, and Kaposi's sarcoma, were often the immediate cause of death. The virus was incredibly difficult to fight because it mutates almost every time it replicates, producing millions of variants that can quickly evade drugs and vaccines. In the early 1990s, no treatment could stop its progression. All of this meant that life expectancy after an AIDS diagnosis was short. Before effective treatments arrived in the mid-1990s, many patients survived only a year or two. The epidemic was particularly prevalent among certain communities, such as gay men, injection drug users, and minority populations. Beyond the health crisis, the stigma surrounding HIV meant that many faced discrimination in schools, workplaces, and even hospitals. It's important to note that the federal government was also widely criticised for being too slow to act. The first cases were reported in 1981, but it took years before the epidemic began to receive sustained national attention. Treatments like AZT, approved in 1987, offered only limited relief and were extremely expensive. This meant that for most patients in the early 1990s, effective treatments were still out of reach, so public health clinics and basic care programs were often the only supports they had. Ryan White and the Care Act. In 1984, a 13-year-old boy from Indiana named Ryan White contracted HIV through a blood transfusion. When his school district tried to bar him from attending classes, his legal battle drew national attention. Doctors said he posed no risk to other students, as AIDS is not an airborne disease and spreads solely through bodily fluids. But AIDS was poorly understood by the general public at that time. White became a symbol of the stigmatization that accompanied AIDS, and he also showed that the disease wasn't confined to any one group. Unfortunately, he died in April 1990, just a few months before his high school graduation. Later that same year, Congress passed the Ryan White Comprehensive AIDS Resources Emergency Act, otherwise known as the CARE Act. It came into effect the following year. It marked a turning point in the federal response, committing hundreds of millions of dollars to states and cities to fund outpatient care, drug assistance, testing, and counselling. Over time, it grew into the largest disease-specific public health program in US history. The CARE Act began with an allocation of around $220 million in 1991. Funding expanded steadily throughout the decade, passing $1.5 billion annually by the year 2000. The money was distributed through grants, with cities, counties, and states receiving funds based on the number of AIDS cases that they reported. But not every place received the same level of support. Some cities with large caseloads became major recipients, while other areas saw far smaller inflows. This uneven distribution of funding would later allow researchers to ask whether communities that received more money actually saw better outcomes. So, what did the research find? Well, cities that qualified for higher levels of funding under the CARE Act experienced large and measurable declines in AIDS deaths. On average, their annual HIV/AIDS mortality rates fell by between 15 and 17% compared to otherwise similar cities that just missed out on higher funding. Translating those percentages into lives, the study estimates that city-level funding saved around 57,000 lives between 1996 and 2018. The effects of funding weren't short-lived either. Even after 1996, when highly active antiretroviral therapy, or HAART, dramatically improved survival, the mortality gap persisted. The reason, the study argues, is that federal funding had created durable public health infrastructure with clinics, case management systems, and outreach programs that continued to matter long after the drug treatments improved. The program also appears to have reduced transmission of the disease, not just deaths. By 2008, cities that had crossed the 2,000 case threshold and locked in higher funding had 36 to 40% fewer people living with HIV than otherwise similar cities just below the threshold. Scaling these effects, Dillander estimates that city-level funding from the CARE Act prevented 324 to 378,000 infections in the years before effective therapy was widespread, and the benefits weren't confined to one group. The composition of the lives saved largely mirrored those most affected by the epidemic, predominantly men, disproportionately people in their prime working years, and disproportionately black. In other words, the program didn't change who was affected, but it significantly improved survival for those communities hardest hit. If you're finding this breakdown interesting so far, and you want to see more videos that unpack economics research like this, consider subscribing to the channel. It would really help this new channel grow. Anyway, how do we know that the Ryan-White CARE Act caused these effects? There are millions of moving parts here. Surely one could argue that the decline in AIDS deaths might simply reflect the passage of time. For instance, medical knowledge was improving year after year. Some might point to the arrival of new drugs like AZT in the late 1980s and HAART in the mid-1990s, which dramatically improved survival. And outcomes might also differ depending on whether a city was rich or poor, or on the demographic makeup of the people who lived there. To get around these problems, the study takes advantage of the way funding was allocated. Under the rules of the CARE Act, a city became eligible for extra support once it had recorded at least 2,000 cumulative AIDS cases. Cities just above that threshold suddenly received much more money, while cities just below it didn't. In every other respect, these places were often very similar. They were dealing with the same epidemic at the same time in the same country. This created what is known as a natural experiment. This is a situation where an arbitrary rule or cutoff assigns some places to receive treatment while others don't. It is not pure randomness, since the cutoff depends on case counts, but cities clustered just above and just below the threshold looked very similar and followed nearly identical trends before the policy. Because it was largely chance whether a city fell just above or just below the threshold, this mimics the logic of a randomized trial and lets researchers see whether outcomes truly differed between the two groups. The way eligibility worked is important. First, the original rules did not take into account whether cases were rising or falling. They only looked at the total number of cases a city had ever reported. That meant two cities with very similar AIDS burdens could be treated very differently, depending on whether they had just passed the 2000 mark. Second, once a city qualified, it never lost that status, even if it later fell below the cutoff. And third, when the CARE Act was reauthorised in 1996, the rules changed to make it much harder for new cities to qualify. Eligibility was now based on recent cases, but with a grandfather clause for cities that had already qualified under the old rules. This timing is also important because effective therapy finally became available in 1996. So, just as it became possible to save lives with treatment, some cities were locked into higher funding while others received much less. Only 2 additional cities qualified after 1996, which meant that the split between higher and lower funded cities remained fixed for more than a decade. These differences weren't the result of how quickly the epidemic was growing in each city, but of an arbitrary cutoff and a rule change. That created large and lasting gaps in funding across otherwise similar cities, which is exactly the kind of variation researchers need to identify causal effects. To measure the impact of these funding gaps, the study uses a method called difference in differences. The idea is relatively straightforward. We compare how outcomes changed over time in cities that qualified for higher funding with how they changed in otherwise similar cities that didn't receive funding. If both groups were on similar paths before the policy, but then begin to diverge afterwards, we can attribute the difference to the extra funding. This relies on what's known as the parallel trends assumption. This is the idea that without the CARE Act, both sets of cities would have continued along the same trajectory. In this case, the data shows that before 1996, the two groups of cities really were moving in parallel. The author also tests this assumption in several ways, and even relaxes it to make sure the results are robust. If you'd like a deeper dive into how difference in differences works, including maths and another example of its use, I explained it in detail in my video on Austria's drug crackdown that backfired. Go check it out after if you're interested. Anyway, we've seen that the CARE Act saved tens of thousands of lives and prevented hundreds of thousands of new infections. But that still leaves a question that might sound very cold-hearted. Was it worth the cost? Public health programs are expensive, and governments have to decide whether the benefits justify the spending. To answer that, economists need a way to put a value on human life. It might sound unsettling, but doing so makes it possible to compare the costs and benefits of very different policies in a consistent manner. How economists don't value a life. I'm going to go on a bit of a tangent here. If you find this part boring, feel free to skip to the next section. There are chapters outlined on the timeline below. Let me begin by asking you two separate but related questions. First, what is the value of a human life? Second, if utility is a measure of a person's satisfaction from a certain state of the world, be it buying or consuming something, or just enjoying something like a sunset, how much disutility or dissatisfaction do we derive from death? I was once asked that second question in a class, and instinctively I thought, surely it's infinite. Death must provide infinite disutility. My thinking probably went something along the lines of, dying means you can no longer derive pleasure from anything, and so death must outweigh any possible benefit you could ever receive. I still to some extent understand where I was coming from, but I was wrong. Let me explain why. In economics, we can think of any action as having an expected outcome. This will equal the expected value of the benefit minus the expected value of the cost. For example, suppose you and I have a bet over the outcome of coin toss. If you lose, you pay me €1. If you win, you get €3. The expected outcome of the bet for you is 0.5, which equals the probability of winning, times 3, which is the reward if you win. We then subtract 0.5, which is the probability that you lose, times 1, the cost of losing the bet. This is equal to 1. For simplicity's sake, I won't include any utility or enjoyment you might get from gambling itself. Seeing as this value is greater than 0, your expected outcome is positive, meaning that unless you are really risk averse, you'll likely take that bet. The costs and benefits don't have to involve money either. I just used the coin toss example as it's relatively straightforward. But decisions like this play out throughout your whole life. We decide whether or not we should go to college, take a job, go on holidays, meet up with friends, or ask someone out on a date. If the disutility of death was infinite, we would never do anything. Should I ask the girl I really like out on a date? Well, let's work out the expected utility. If she says yes, let's say there's a 60% chance I might enjoy a nice meal, get to spend an evening with someone I really like, maybe even fall in love, get married, have kids, and add an immense amount of utility to my life through all of these things. Now let's consider the expected cost. Well, there's the cost of the meal, maybe transport to and from the date, and then there's the chance that I die. I might get hit by a car, I might choke on my food, I might fall so head over heels for this girl that my heart just explodes. All of these things are incredibly unlikely, but there's a non-zero chance of them happening. Even when we multiply negative infinity, our disutility of death, by a really small number, it's still larger than any possible benefit we could get from the date. And so, if the disutility of death was infinite, we wouldn't go. Yet, we still do things, and so, the disutility of death must not be infinite. Similarly, the value of a life must not be infinite, both in terms of how we value our own lives, but also in terms of how governments value lives. Suppose for a minute a single life was worth an infinite amount. Then, a government is faced with two possible policies. Policy A makes everyone's life much better off, but does not change the probability of anyone dying. Policy B makes everyone's life much worse off, but one single person has a 0.00001% lower chance of dying. Policy B would provide a greater welfare outcome. Again, lives must not be worth an infinite amount. This isn't because economists are cold, heartless machines. It's just because infinities break mathematics. This framework that life is valuable, but not infinitely so, is how economists evaluate whether public health spending, like the billions poured into fighting AIDS, was worth it. So how do economists value a life? The most common approach is called the value of a statistical life, or VSL. This doesn't mean putting a price tag on any one individual. Instead, it measures how much people are collectively willing to pay to reduce a small risk of dying. Let's take a very basic example. If a group of workers demand an extra $1,000 each to take on a job that increases their risk of dying by 1 in 10,000, then together they are willing to pay 10 million for one expected life lost. That 10 million figure is the value of statistical life. It's a benchmark used widely by US agencies from the Department of Transportation to the Environmental Protection Agency when deciding whether a safety regulation or environmental rule is worth the cost. And this is the metric that Dillender used to judge the Ryan-White Care Act. By combining city-level funding records with the mortality reductions, the study estimates that the programme spent about $334,000 per AIDS death averted. Compare that to a VSL of around $10 million, and the benefit-cost ratio comes out at roughly 30-1. Even if we only consider deaths averted, ignoring infections prevented and improvements in quality of life, the programme was extraordinarily cost-effective by the standards used in health economics. Beyond the Ryan-White Care Act, there's more good news. Today, HIV is no longer the death sentence it once was. Thanks to antiretroviral therapies, most patients in high-income countries can expect a near-normal lifespan. But the Ryan-White Care Act is still going strong. It continues to fund treatment and support services for more than half of Americans that are living with HIV. The programme shows what's possible when governments invest heavily in public health, even in the face of stigma, controversy and uncertainty. Over its history, the Ryan-White Care Act saved more than 57,000 lives, prevented more than 300,000 infections, and did so at a cost that looks tiny compared to the value of the lives it preserved. Based on the standards that economists use to judge safety rules, environmental policies, or infrastructure projects, it stands out as one of the most cost-effective public health programs in US history. If you'd like to see more videos about economics research and how economics unfolds in the real world, make sure to subscribe and hit the bell icon so you'll be notified when the next video comes out. This video is based on a research paper by Marcus Dillender. You can find a link to the full paper in the description below. I'd also like to give a massive thank you to Marcus for agreeing to proofread the script and help ensure its accuracy. Thanks for watching, and hopefully I'll see you next time on Econ Unpacked.